Hi, everyone. This is Lynn Crawford with HOPE Dementia Support, and we are so fortunate this evening to have Scott Losk here, who is a principal investigator for Summit Research, the Headlands site in Portland. And he has some wonderful things to tell us about clinical treatment and research for cognitive and behavioral changes in dementia. Now, a thing to remember is that you have the opportunity to put your questions in the chat or in the Q&A, and Scott has indicated that he is willing to break every so often and answer questions. So we're going to introduce him and let him tell you a little bit about himself. Thank you all for being here.
Thanks, Lynn.
Scott, it's all yours.
Thank you. Thank you. Good evening, everyone. Scott Losk here. I am a principal investigator for clinical trials research at Summit Research. And you'll see the slide there. It says a Headlands site. A few years ago, we sort of got together with a number of other research sites in North America and put together a consortium of research centers to do this kind of research, central nervous system and um, cognitive impairment, depression, bipolar disorder, those kinds of things. But we also do metabolic research with various kinds of GLP-1 approaches and those kinds of things. So um, I've been with Summit Research for 36 years, since 1990, and we've been conducting clinical trials in Alzheimer's disease and other conditions since that time. Just by way of introduction, if some of you saw this pamphlet the other evening, boy, wasn't that a beautiful evening the other evening at the fundraiser for those of you that were there? um, well organized. Wouldn't you love to be able to capture and somehow apply Amy Schmidt's energy to your life? She's just very impressive that way. Um, and then, of course, Larry did a beautiful job with his presentation of music, the neuroscience of music. But I wrote this trifold a month or two ago, and so if any of you are interested in it, I'm happy to take your email. We can get a list going, and we're happy to uh, send this off to you all. And it's a summary of what's going on in current clinical research um, and it may be applicable to your situation or someone that you know and love. Um, Hope dementia is new to me. I spent many years back in the 90s doing presentations for the Southwest Washington Support Network. Some of you may remember Opal Swanson and Shanti Potts, who ran that group. And I think the group was eventually folded into Alzheimer's Association and various forces. But one of the things that's been impressive about the geographic area of Southwest Washington is it's always been very strong in its support of people who need extra support, whether it's the walk to end Alzheimer's disease, whether it's the support groups that Hope has. It's a powerful community, and uh, it's a good example the other night of the attendance and the excitement about what's going on. So we're going to talk about the current landscape of clinical treatment and research for cognitive and behavioral changes in dementia. And when I say landscape, kind of like a mural or kind of like a broad brushstroke, we're going to cover a lot of different things. But we always have to start with, we're not going to get into a bunch of epidemiology, but we are going to get into just a little bit of the neuroscience and the neuroanatomy of what we're talking about. So this is a slide that many of you have probably seen, and you probably recognize that this depicts the presence of beta amyloid. That's these brown spots here, right? Beta amyloid. And then the blue is supposed to represent hyperphosphorylated tau or neurofibrillary tangles, right? So these are the pathophysiology that initiate the process of Alzheimer's disease. And here's something, some of you already know this, but here's something it's going to be shocking to some of you as well. Beta amyloid, this brown stuff, this stuff starts to build up somewhere between 18 and 20 years before a person has any cognitive symptoms. Okay, 18 to 20 years, this what we call plaque, beta amyloid plaque. And the beta amyloid plaque sort of sets the stage for the neurofibrillary tangles that occur on the inside of the neuron to take hold. So 18 to 20 years for amyloid to start. And then 2 to 3 years before the onset of symptoms, we see tau protein developing. Okay. Why is this important? And why does it lead to what a lot of what we're doing in research? Well, we know that if we can somehow manage amyloid early on in the course of the disease, we've got the potential to reduce the development of tau protein. In addition, we know that beta amyloid is a problem. It's a pathology in the brain, but it does not correlate highly with cognitive decline. Okay, I know that sounds unusual, but a person can actually have a lot of amyloid in the brain and minimal cognitive decline, or less amyloid and a lot of cognitive decline. But what amyloid does do is it sets the stage for the development of tau protein. And it's the tau protein that correlates most highly with cognitive decline. Right? So as we talk and we get into some of this later on in the presentation, you'll see that a lot of the current therapies are oriented toward amyloid lowering, and this is the main reason why. So some early pathology. So you just saw a slide that was at the microscopic cellular level. Okay? And this slide here was as sort of simple and straightforward as I could find that gets us at the brain regional level. So let's start over here. Amyloid plaque stages. So front of the brain, back of the brain. This is the temporal lobes. And what we're talking about here is the very inside, what we call the mesial portions of the temporal lobes that are affected earliest and most by the presence of plaque. All right. So we're talking about, like I said, somewhere between 18 and 20 years to get to this point. And then as it progresses in green here, it starts to progress frontally and then in the parietal lobes. And then we also see a little bit in the occipital lobes as things continue to progress. So theoretically, if we're talking about clinical staging, we're talking about mild cognitive impairment here, mild to moderate dementia here, and moderate to severe dementia here. So Brock and colleagues about 30 plus years ago identified the presence of stages of tau development. And you'll see amyloid developing here, tau starting to develop here, even in MCI. As we move into mild to moderate stages of dementia, the tau progresses along the parenchyma here, and throughout the temporal lobes, medially and laterally, and then eventually the entire brain is affected. So you see this down here, it says 30 years. Remember what I said about 18 to 20 years for a small amount of amyloid to build up? That's how long this takes. And down below, it's maybe as long as 50 years before we get to this point. So, really what we're doing here, we're identifying the pathologic process, but the purpose of this is to be able to intervene at a place where we can prolong highest quality of life, and that's driven by the highest level of cognitive functioning, right? So if we can all get to whatever our God-given natural age is going to be, 80, 85, 90, 95, 100, if we can get to that point before we start to drop, then we've dramatically changed things. We've dramatically changed things for individuals afflicted, for families, for loved ones, for finances, and the whole thing. So these are the stages, and many of you have seen these pictures before too. The top is amyloid, the bottom is tau. So we've got the amyloid PET scans here. We've got the tau PET scans here, so-called florbetapir and flortaucipir. So here's an amyloid negative PET scan. That's what you want it to look like. Once it becomes amyloid positive, we see the presence of amyloid in this darker red and just a small amount of tau protein. Once the person gets to a higher level of amyloid and actual clinical symptoms related to Alzheimer's disease, then we see a lot more, and we see a lot more tau protein. You'll hear me say this over and over. A lot of our studies now are intervening at these stages, and some studies are actually intervening at this point. So it's exciting. It's exciting that we can kind of identify who's going to be at risk and how we might be able to intervene at an early point. Okay, so many of you have seen this picture. You'll notice in the title I use the term dementia. I didn't just say Alzheimer's disease, although I am going to be primarily focused on Alzheimer's disease. Looks like I may have lost my video here. Sorry about that. I'm not sure why that happened. Uh, so we'll just go through this real quickly. And I put this in simply because I'm sure some of you are coping with loved ones who have different types of dementia besides Alzheimer's disease, even though Alzheimer's is the most common as we get into older ages, accounting for 60 to 70% of all dementia. Um, Vascular dementia, maybe 10 to 20%. Frontal temporal dementia, less than 10%, maybe 5%. Lewy body disease, in my experience, and when I review the literature, this is more like 15%. And then other dementias, Parkinson's dementia, Huntington's, Jakob-Creutzfeldt disease, and others make up the hmm, rest of dementia. So most experts believe that there's very little pure Alzheimer's. It's usually Alzheimer's plus a little bit of vascular, Alzheimer's plus a little bit of Lewy body or alpha-synuclein, what we see in Lewy body disease and Parkinson's disease. And so most dementia, to be perfectly honest, is some combination of mixed. Um, the frontal temporal dementia looks very different. These are individuals, for some of you who might be caring for people with this condition, it's personality changes first. It's suspiciousness, neuropsychiatric symptoms first. The memory and cognitive symptoms come later. And unfortunately, because the frontal lobes are responsible for awareness, self-reflection, empathy, a person's ability to put themselves in the shoes of others, this is a very difficult condition, frontal temporal. You cannot convince people that they have compromise. Um, so in Alzheimer's disease, again, we're going to focus primarily on that tonight. Uh, the initial symptoms are always cognitive. It's always new learning and memory. It's always naming problems. It's always language problems. And then as we progress, we move into visual spatial impairment and other kinds of cognitive changes. And then sometimes and some studies have actually suggested this um, that mood-related changes, depression, especially, and anxiety. There's a recent study looking at anxiety may actually be prodromal to the cognitive symptoms. And I don't have a picture of this, but if I did, I'd be able to show you that the memory centers of the brain and the mood centers of the brain are next door neighbors. So it's part of the reason why we see so much in the way of neuropsychiatric symptoms. Okay, my slides are not moving forward here. There we go. All right. So very familiar face here. And the reason this face is in this presentation is because this gentleman, Ronald Reagan, is a classic example of Alzheimer's disease occurring in late life and uh, onset of his Alzheimer's was probably in his early 80s with diagnosis around age 83. He lasted for another 10 years or so before death. And odds are that he was probably making decisions in office in a memory impaired state. Um, so the reason I put this in is to show you this is a classic example of later onset Alzheimer's disease. Now, we all recognize Glenn Campbell. This is a wonderful picture. And for some of you, his music, I'm sure, touched your hearts, and maybe you have, um, life events where his music was played, and you have fond memories of listening to his music. Glenn Campbell had the onset of his dementia, although not diagnosed until his early 70s. Onset was likely in the early 60s. Probably mid 60s. Probably essentially an early onset Alzheimer's case. Remarkably, though, as some of you know who followed him, he was able to continue with his musical prowess well into his memory impaired state. He was able to play his songs, sing his songs. He did a final tour performing his songs. And in his tour, he was very memory impaired, but able to perform. Another example of how overlearned behavior is, is something that is often stays even as the memory gets worse. Okay, you all recognize this gentleman. This is Robin Williams. Um, Robin Williams, some of you probably loved him. Some of you probably didn't. His humor, I think, he was brilliant. Um, I was not a huge fan of his humor. I think he just moved along too fast for me and spoke too fast. But he was brilliant. And uh, he was a victim of dementia with Lewy bodies. Okay, in his late 50s, he started to have visual hallucinations. His mind would play tricks on him. I lost my camera again. Sorry about that. Not sure why the camera keeps going out, but Dementia with Lewy bodies, neuropsychiatric symptoms early, um, and he had the typical REM behavior sleep disorder, so that was a factor as well. So he couldn't sleep. His mind was being hijacked, um, and eventually he couldn't tolerate his condition, um, and he committed suicide. Uh, his wife wrote an article in that was published in Neurology that was called, it was either the devil, not the devil, it was the demon or the devil inside my husband's brain, and it was a quite uh, an amazing article reviewing what he had to go through. Um, so that's that's a Lewy body situation, and then sorry about that. Okay. And then many of you recognize this gentleman. This is Bruce Willis. You know that he has frontal temporal dementia and some disinhibition, but a lot of apathy. And when the frontal lobes become chronically impaired, that's what you get. So there's no more die hard, no more testosterone charged behavior and activity on this gentleman's part. So a late onset case, an early onset case, dementia with Lewy body, and then frontal temporal dementia. Just letting you know that, celebrities obviously are not immune to this, and it can affect a broad diversity. Okay, so um, the importance of early diagnosis. And I promise we will get to behavioral interventions in just a bit, but let's talk about this importance of early diagnosis. You heard me say earlier about the relationship between amyloid and tau development. So 18 to 20 years before the onset of symptoms, amyloid comes in and it lays the stage for tau development. In addition, secondary pathologies, neuroinflammation, uh, the inability for the brain to get rid of free radicals, um, oxidative stress, those secondary pathologies all occur as a result of of amyloid and tau buildup. So the idea here is to be able to intervene with medication or other interventions before the brain is significantly compromised. Once the tau has taken over, there's so much neuronal damage that we have a hard time influencing neuronal functioning with medication. Okay. So this last point here, I note intervening with the compound to preserve as much brain and cognitive function before the next best compound is developed. This is kind of what we see in cancer, right? For some of you have dealt with this yourselves or have loved ones who are on a chemotherapy and doing pretty well. It stops working, or a person's been in remission, then they relapse and need a new therapy. So we're hoping that we can do the same thing with this condition. Okay, so sorry about that. Okay, so quickly. This is revolutionary stuff in the last 7 to 10 years. It used to be that a loved one would bring someone into my office and I'd do a neuropsychological exam, and the person would have symptoms of dementia, memory loss, and other cognitive change. And I'd let them know, give them the feedback, and talk to the primary care doctor or the neurologist, and they would maybe prescribe Aricept or one of the other cholinesterase inhibitors. And really, it would be too late. Today, we can do these. So these are all blood-based. These are blood-based. Now, they're mostly in research, but these are blood-based biomarkers. So we've got biomarkers of A beta pathology, beta amyloid. We've got biomarkers of tau pathology. This p-tau 217 biomarker here is what we use in almost all of our studies. It correlates 0.93 with amyloid in the brain, as well as tau buildup, as well as these other tau pathology biomarkers, biomarkers of neurodegeneration, NFL, and total tau. And then we've got these neuroinflammation biomarkers as well, GFAP and TREM2. So this is really remarkable that we're able to look at blood in such a way so that we can find out at a very early stage. Okay, we're going to talk about this one last slide, and then I'm going to stop and answer any questions that you might have. Uh, the slide's a little bit complicated, but what we've got here, uh, if we look at the top where it says max, you see that at the top, it says central or cerebral spinal fluid A beta. Okay, so that's beta amyloid that we see in cerebral spinal fluid. The orange line there is what we see on an amyloid PET scan. The blue line is the cerebral spinal fluid tau volume, and the purple line is MRI plus FDG PET, and then the green line is cognitive impairment. So that whole on the if we move to the right of the diagram there, the cognitive impairment section, normal MCI dementia. So why is this important? If we go to the left, so we can detect all these biomarkers while a person still has normal cognitive functioning. You see that detection threshold, that line across the x-axis? We can detect those biomarkers while a person still is doing well and without cognitive impairment. And over time, a person develops MCI when these values are all actually quite elevated, all right up in this range. And then dementia doesn't occur until this range. So this is a beautiful thing that we can track these changes early and identify change at a very early point. Okay, so let me stop here, and Lynn, maybe if there are questions, I'd be happy to answer any questions at this point. Any questions about pathology, about early diagnosis, about we're going to get into the treatment of cognition and behavioral symptoms in a bit, but if there are questions now, I'm happy to answer them.
So I have a bunch of questions. Here's one. Um, are the blood tests approved?
The blood test, the p-tau 217 is approved. Yes. Uh, it's the one that's used most often, and it's rarely in the primary care doctor's hands. They rarely know about it. All neurologists know about it. Um, whether your insurance will pay for it, that might be another issue. But yes, the p-tau 217 can be obtained.
And from your perspective, what are the most promising clinical interventions currently emerging for Alzheimer's and related dementias?
We'll talk. That's the next part of the talk, and we'll talk about both amyloid lowering therapies, anti-tau therapies, harnessing harnessing glial cells in the brain to go out and kind of clean up the garbage around neurons. For some of you who remember your basic biology, it's called phagocytosis. Glial cells go into other parts of the brain and do cleanup work. Um, and then we've got some compounds that lower oxidative stress, that reduce neuroinflammation. There's all kinds of stuff, and we'll get to that in just a bit.
Well, I have a bunch of other questions, but I think you may be answering them as you go forward. So
Okay.
I hesitate to ask. I think we'll wait and see.
Okay. Very good.
Okay.
Okay, so let's talk. We've talked about the background. We've talked about the neuroanatomy. We've talked about the fact that no one's immune to developing these cognitive disorders. We talked about the basic blood-based biomarkers and cerebrospinal fluid biomarkers. Now we'll talk about cognitive and behavioral symptoms and what we're doing for intervention. So as you know, and this is specific to Alzheimer's, at least with regard to the cognitive change. Um, New learning and memory and language impairment, primarily confrontational naming, the ability to use the right word in the right place, the ability to um, come up with names for people and places that should be familiar. I mean, so some amount of naming change occurs for all of us, regardless of our status. But this is compromised naming and compromised language, and then we see changes in visual spatial skill, executive functioning, reasoning and judgment, those kinds of things. So you heard me say earlier. Um, Behavioral and psychological symptoms of dementia, so-called BPSD. Uh, High numbers of individuals are affected by this. So it can be anything from a very mild amount of anxiety or a mild amount of depression, which may be reactive to cognitive change, or it may be a part of brain-related change, right? So it could be a reaction to not being able to perform as well, but it could also be at the level of brain functioning, the mood centers of the brain not working as well as they used to. Okay, the bottom line is a high percentage of people experience these things, and the anxiety part, the depression part, for many people can be reasonably well managed. Some of the other neuropsychiatric symptoms, the suspiciousness, the paranoia, the agitation, the restlessness, the striking out, those kinds of things, uh, that's another level uh, of behavioral problem. And there are medications. There are medications that have been used off-label, and at least one medication that's approved by the FDA. And we'll talk about those in just a little bit. And then, of course, these symptoms and the cognitive decline, the behavioral decline, eventually the physical changes that occur are major drivers of caregiver and financial burden. Um, and So this is why, if we can get to the place where we're the prevention place, like I mentioned earlier, and I'm going to talk about again later, but also just prolonging the level of functioning, uh, 2 years, 5 years, 7 years, so that the disability is less, because it's the disability, it's the impairment that causes such burden on caregivers, and the fact that this person that I've known for so long in such a fashion, in such a emotionally intimate capacity, is no longer able to engage in that. And so this is the race that we're running, and that we're trying to get ahead of. And even buying uh, a couple of years or longer is it can be of significant value. So, uh, as all of you know, the treatment of cognitive symptoms, the mainstay are cholinesterase inhibitors, memantine, and they provide symptomatic benefit. So, I'm going to tell you a quick story here. Most of you are aware of a medication called Aricept or donepezil. It's been the mainstay of treatment since 1997, so for almost 30 years. Um, but it wasn't the first medicine that was approved. In 1992, we did research on a compound called THA or tetraaminohydroacridine. Uh, and It was actually approved in 1992. It was also a cholinesterase inhibitor and lasted for 5 years or so before Aricept came on. Eventually, it was taken off the market because liver function changes. But it was an early compound that I actually worked on back in the 80s. I was in training in Southern California, and we were doing a trial uh, at Huntington Memorial Hospital in Pasadena. Um, I was working with a couple of other doctors on this trial, and we were able to demonstrate that people benefited from receiving THA, and eventually it was picked up by a company that no longer exists, Park Davis, and then purchased by Warner Lambert. In any event, so the very first treatment was 1992, then donepezil in 1997, and then in the late 90s, galantamine came on board, um, and then eventually rivastigmine, and that's Exelon. And the Exelon patch was available for a bit, and um, later on, there was a combo treatment with donepezil and memantine uh, called Namzaric. I believe that's still available. Um, Memantine was approved in 2003. So it works a little bit differently. The cholinesterase inhibitors work to enhance acetylcholine in the brain. That's a memory chemical that your brain needs to be able to learn new information and recall it. It's not required for the recall of old information. Memantine works by modulating glutamate. All right. What we see in the brains of people who have Alzheimer's disease is overactive glutamate. And so, under conditions of what we call excitotoxicity, um, a damage can be done to the brain. So memantine, under the excitotoxicity state, uh, it basically blocks glutamate from having any effect, and does its work that way. The memantine, frankly, there's a minimal cognitive benefit. It's most beneficial for behavioral symptoms. So if if some of you are experiencing agitation with your loved one, restlessness, mild to moderate anxiety, those kinds of things, and have not tried memantine, the trade name is Namenda. Namenda. Uh, very few side effects, uh, and a lot of benefit for behavioral symptoms. It wasn't approved for that, but a lot of benefit off-label. So this last point here with the stethoscope, these compounds treat symptoms. So we're treating the neurocircuitry of the brain, the neurotransmitters of the brain. We're not getting at the underlying pathology that I showed you earlier. Okay. Okay, I lost my video again. Sorry about that.
While you're waiting, can I ask you a question?
Can you hear me okay?
Yeah.
Okay, yeah, please.
Okay. So this person says, I've heard recently that there has been discussion about why research is based almost solely on amyloid and tau. The current drugs are doing very little to help. There's a question about whether there may be other causes of dementia and why we aren't pursuing these as well.
Yes. Um, it's a great question. And the reason we're going after amyloid is because it's a substrate that we've been able to identify that seems to be related to early Alzheimer's. We're going to find um, so many other factors in addition to tau protein. Um, uh, like I mentioned earlier, glial cells, that are supportive and have a cleanup mechanism in the brain. Um, and this is, I mean, for now, this is our best effort. It's just our best effort as a field. There and it's identifiable. Um, in the future, what things are going to look like are very much uh, uh, cocktail kinds of approaches for managing a broad diversity of conditions. So,
So, few more questions, if that's okay, until we see if we can get your slides up. Is how can we help families feel more comfortable engaging with clinical options without it feeling overwhelming or medicalized?
okay. Am I, can you hear me now?
Oh, we have you.
Okay. We'll
Are
see. We'll see. Do we have the slides?
Julie, have we got his slides?
I don't see
No, I
them.
have not received them yet.
Yeah.
They're not shown up yet.
Okay. That's all right. Can we do our Q&A while we're waiting?
Sure. Yeah. Let's do it.
Okay. Where do you see the strongest opportunities to connect clinical research with community-based organizations like ours?
Oh,
Oh,
what a great question. What a great question. Do you have the slides back now?
yes, we do.
Okay, great. Um, this is all, it starts right here. It starts with education and just talking. Um, and then awareness of the fact that some of these opportunities are available in research. Um, so I think that's where it starts. One of the things that COVID did is make us, sort of pretty comfortable, not interacting face to face with each other and doing more of this. And granted, it is certainly easier, but I think interacting face to face, like you guys are able to provide the support face to face, because you know, the whole the whole structure of being able to lean on me, like we sang the other evening, is about face to face. And it takes a while. It takes a while to build up trust. So we just need more face to face time together is the main thing. So um, other questions?
Oh, a bunch, but if you want to go ahead
Yeah, let's move
with your
through. I'll move
slides,
through
that's
this
fine too.
relatively quickly and get to the behavioral stuff. Mm. And I really apologize for this technical stuff. I'm not sure what this is about, but so the monoclonal antibodies that are available for treatment include lecanemab and donanemab. We have a number of others that are in research right now that are more precise and cause less what we call ARIA. Those are the amyloid-related imaging abnormalities. These compounds are available for people with mild cognitive impairment and mild dementia. Once a person has moved beyond that point, they will not be of benefit. A recent Cochrane meta-analysis came out last week. Some of you may have seen it, um, and they looked at 18,000 people who had been in multiple studies with monoclonal antibodies, including the monoclonal antibodies that had failed in the studies, and basically demonstrated that there's no benefit in this meta-analysis. So I don't know that that's true because we do see some benefit in with certain monoclonal antibodies, especially these ones that were approved. Um, and and frankly, I have a handful of people who had MCI in 2018 and 2019 when they entered one of my studies with lecanemab. It was double blind for 18 months and then 3.5 or 4 years of open label treatment. And they're unchanged in terms of their cognition. So I realize that's remarkable. And this is not, this is not statistically analyzed. This is anecdotal. But we are seeing some of these kinds of kind of remarkable responses. Um, okay. We are going to skip through this. This is mechanism of action of how these monoclonal antibodies modify the disease. It's fascinating stuff, but in the interest of time, we're going to skip through it. Um, so, what's going on in research right now? In addition to the monoclonal antibodies that are administered by infusion or injection, those are the ones that have been approved by the FDA. We also have oral anti-amyloid compounds in research right now, which intervene before the plaque becomes mature, when it's at the level. We lost my camera again. I don't think I'm going to worry about my camera. I don't want to mess the rest of this up. Can you still hear me?
Yeah, we can hear you and we can see the slides.
Okay, great. I'm not going to worry about that. The oral anti-amyloid compounds intervene at the point uh, of beta amyloid oligomers. So before we have mature plaque is when these intervene. These monomers, dimers, and oligomers, and so they, in the cycle of plaque development, they intervene at a very early point. I mentioned glial cells before. We can harness other structural cells and cleanup cells in the brain to do neuronal activation. These are largely the TREM2 activating compounds. And then, hey, there's a term that you guys recognize, GLP-1s and neuroinflammation. The world is awash with GLP-1 um, uh, potential benefits, right? We know that GLP-1s help with diabetes. We know they help with weight loss. We know that they help with cardiovascular prophylaxis. We know that they help with kidney prophylaxis. We now know they're not approved for it yet, but we now know they're helpful for people who have substance issues. We've done some substance abuse studies with GLP-1s with really quite remarkable responses. In addition, psychiatric disorders like depression and anxiety, when you look at the secondary measures of studies with diabetes and weight loss, they always measure mood, but these secondary measures all show improvement for people who have received GLP-1s. For those of you who have followed the field, a large study that was conducted by Novo Nordisk and reported on last fall with semaglutide, with Ozempic, failed. So that failed in a phase 3 double-blind placebo-controlled study um, of a couple thousand patients. And I think more research in memory loss is going to be done with GLP-1s, and it's probably going to end up being helpful. Um, I'm actually surprised that it wasn't helpful this time. I think it was a study design issue, though, rather than the actual compound. So more to come on GLP-1s. So non-pharmacologic interventions. Okay, let's talk about this. I know you guys talk about a lot of this stuff in the support groups. You read a lot. You get yourselves educated. I think one of the best interventions is to to look at yourself in the mirror and do your very best to make a paradigm shift. Okay. So the person that you're caring for, this person that you've known and loved for so many years, the person you're caring for is the same person, but because of memory loss and other cognitive changes, cannot play the same role in the relationship that they always have. Okay. So when I say paradigm shift, I'm talking about sometimes the roles need to change. And I realize you guys discussed this, but this is a real thing that so many of my families have a difficult time changing. And that is, and it happens more with men who are caregivers for their spouses than it does for women who are caregivers for their husbands. But it's really a very important transition because once you realize you make that paradigm shift and you realize that asking for the person's opinion, asking for your loved one what they want for dinner or what they'd like for dessert or what they want to do for the day, you realize that that's a question that is can be too difficult to answer. So the intervention, of course, is we're either going to do this, it's something that you've always enjoyed, and we go, or we're going to do this or this. Which would you like? Not asking the person to come up with the answer on their own, right? It can cause anxiety, it can cause frustration, it can cause communication issues. So these are role changes. The role changes in the course of a marriage, role changes in sometimes a parent-child, um, and we want to do our very best to be, like the second point says, person-centered, and to, as necessary, modify the domicile to make it easier for people to function. But that first step of making that change on your own and talking it through with friends and family. What do I need to do to be more effective here? Uh, is an important piece. Uh, so obviously, uh, you talk a lot about redirection. You talk a lot about staying mildly to moderately stimulated with other activities, calming music, calming presence, nature sounds, those kinds of things. The importance of regular exercise, all that kind of stuff is important. Now, with that being said, technology can really be helpful here. I have a number of families with loved ones who still insist on living independently, and they do it, but they do it with the aid of cameras. They do it with the aid of the Alexa or the Google device so that they can communicate with their loved one at a moment's notice. So the utilization of technology can be very, very helpful in this regard. So pharmacologic treatment, uh, really, we're always best off to do the least intervention before we get into the heavier stuff. So the lighter intervention are things like um, SSRIs, right? So things like Zoloft, small amounts of citalopram. You want to avoid fluoxetine. Fluoxetine is Prozac. It's got a longer half-life, generally not indicated for older folks. Usually, the lower dose of sertraline, 25 or 50 milligrams, is a good place to start. And with your docs will be most comfortable going, okay, well, we usually start at 25, or we usually start at 50, or we usually start at 75. In many cases, toleration of these medicines is limited. So the starting point is not the most important thing. The toleration of the medicine is the most important thing. So you might have to start at 5 milligrams or 7.5 or 10 and gradually work your way up to 25 to make sure the person tolerates it. Okay, so that's the SSRIs. Brexpiprazole is Rexulti, and that was approved for agitation in Alzheimer's a couple of years ago. Low doses, 0.5 to start, maybe working up to 1 or 2 milligrams. Rarely do you want to go above 2 milligrams of brexpiprazole. Okay. Um, so we'll talk a little bit more about behavioral interventions, I'm sure, in the question and answer, but The word, here's the hope for the future. And so we're kind of shifting here to a future orientation, and that is uh, we're doing trials right now with folks who don't have cognitive symptoms, people who are p-tau 217 positive, people who might have amyloid on their PET scans, and they're getting involved in amyloid lowering and other trials. Um, the combination trials are also happening with the Altoida device and a few other technological devices that allow a person to sort of stay independent longer. I mentioned the biomarkers, both the blood-based biomarkers and cerebral spinal fluid allows us to do the early detection, the early diagnosis, and consequently early intervention. Um, and we talked about the digital and the more AI-oriented stuff. So this final table just talks about the various domains, the domain on the left-hand side, cognition, agitation, psychosis, apathy, care delivery, current standard and what we're moving into, cholinesterase inhibitors and memantine. And then we do have some anti-amyloid compounds for MCI and mild dementia. And there will be more combination therapies, more cocktails as we move forward in research. Same for the management of agitation and psychosis. Um, Apathy, for some of us, especially with the Parkinson's type dementia and Lewy body type dementia, sometimes apathy is a serious problem. Tiny amounts of stimulants can sometimes benefit that, but that's usually going to be done in the hands of a behavioral neurologist or a geriatric psychiatrist, and then digital and AI tools. Okay, so again, reasons for hope in the future. Um, Early identification before symptoms actually start. Routine screening. I think this is going to be the wave of the future. Both cognitive evaluation and blood-based evaluation in the primary care office, routinely at age 65 and probably starting at age 55 for people who have a positive family history or know their APOE status, APOE4 status. Um, the genetic talk, because that's another full talk. We can do that later. Um, and then moving to compounds that rapidly lower amyloid and tau protein, preserving as much brain as possible. And then, of course, the lifestyle interventions. We had, again, at uh, the Hope Dementia fundraiser on Saturday, Dr. Sherman talked at length about the importance of music for a brain and keeping a brain healthy. But of course, vigorous exercise. Um, and why exercise? Why do that? Are we just increasing blood flow to the brain? And the answer is no, absolutely not. Do we increase blood flow to the brain? Yes. But the main reason exercise is beneficial is because a chemical is created when you exercise vigorously called irisin, and irisin promotes BDNF, brain-derived neurotrophic factor. When you enhance BDNF in the brain, you preserve cognition as what you do. Recently, within the last month, a new study was done looking at the liver. You all know about the gut-brain axis. There's now a liver-brain axis that helps uh, promote the development of this compound called um, phosphatidylinositol, D1. And when you enhance that, when you exercise vigorously, you enhance that chemical, the liver sends it to the brain and it helps keep the blood-brain barrier intact, and which tends to change over time and definitely changes dramatically in progressive dementing disorders. So exercise is not just blood flow, it creates all this other good stuff. You got to sleep well. If you're going to have a healthy brain, you got to sleep well. And if you don't, really work hard to try to get that figured out. I know a lot of people don't sleep well, but it's a very, very important piece to the whole brain wellness and keeping the brain well. The diet, we talked about that earlier, a little bit about omega-3 and fatty fish and um, sardines and fish oil supplementation as necessary. Uh, so the bottom line is, the brain doesn't love carbs so much, and high protein and high omega-3 diet is best. Um, and then, of course, stimulating social and cognitive activity. So, hope for the future. And again, I apologize for my camera. Now, let's see if we can make it work again. No, just briefly. Okay, camera's not going to work. Question time.
Um, Here's one. Is there a relationship between cortisol and dementia?
Oh, that's a great question. That's a great question. Um, Cortisol is a normal hormone that's produced when we need to exert, when we have anxiety, when we uh, just have a higher level of arousal. So, under normal circumstances, when you exert or have a higher level of arousal and then you go back to your normal state, the answer is no, it does not. However, the brain does not like to be anxious. The brain does not like to be depressed for long periods of time. So, what I'm saying is chronic high levels of anxiety increase levels of glucocorticoids, of which cortisol is one, and your brain, especially your hippocampus, the memory center of the brain, does not like that. So, it's kind of a double-edged sword. You need cortisol to be able to function. You just don't want it chronically being pumped out.
I had a question related to treatment for vascular dementias and how is that different?
Right.
Um, can the same medications be used for vascular dementia or most of them just for Alzheimer's?
Lynn, do I still have you?
Yeah, did you hear that question?
I did.
Okay.
Yes. Our interventions are at this point are not different. I wish they were. Uh, the management of vascular dementia is really it's really about managing cardio and cerebrovascular risk factors, and then treating symptomatically with the same medicines we use for Alzheimer's, to see if we can get some benefit there. Um, Unknown if we are, um, but it's a tough one, and especially with vascular dementia, we see a broader range of cognitive and symptomatic changes simply because it doesn't follow necessarily the same pattern that we see in Alzheimer's disease. It really depends on where the person has the vascular change and what part of the brain is being affected. I mean, generally, a person uh, kind of has what we'd refer to as just generally slowed cognition, slowed interactions, decreased attention, those kinds of things. Um, Memory may not be quite as affected, but we're not we're not fantastic at the management of vascular disease at this point. So, next question.
What do you have to ask the physician in order to secure a blood test? And I have to say that I have had a number of people tell me about questioning their physician about a blood test, and the response is, well, why?
Right, right. Well, I would say uh, these articles on p-tau 217 blood-based biomarkers. Um, you can get there's two or three articles in JAMA that you can pull. if you can just do a Google search, pull the article in JAMA, and take it into the doctor and say, hey, look, this is being done in research. It's been being done in research for 5 to 7 years. It's now available clinically. The FDA approved the first um, uh, Lumipulse p-tau 217 test last summer. Uh, we want to do this. We want to find out. It helps conclusively know uh, what's actually going on. It may not point toward a treatment, but it helps confirm the diagnosis if a person is positive. Conversely, if a person has, say, no cognitive impairment, but they have mom and dad both had Alzheimer's disease and they have a positive p-tau 217 test, that's not a diagnosis. But it does put a person at higher risk. It's higher risk for decline.
The question about why would you wait until 65 to test if the goal is to inhibit tau?
Yeah, it's a good question. Um, I just think that uh, I think a lot of things happen, culturally at that age, and I think insurers and others would be most likely to cover those kinds of things in an annual exam at that point. Um, but certainly for people who have a family history, or if they know their genetic status, the earlier the better.
And the question about creatinine and methylene blue.
Oh yeah, yeah, I saw that from earlier, right? Uh, so creatine is
Creatine, sorry.
it's being looked at now. We know it's being looked at in depression and cognitive enhancement and stuff as an energy generator for the brain. Um, so it's a thing. The thing is, doses need to be pretty high, and other factors need to be monitored, like thyroid and other things to make sure that they don't get out of whack. But we're going to see more and more about that. We're also going to see more and more about, like we saw last summer, about lithium orotate, not carbonate, but lithium orotate in small doses, probably being cognitively beneficial. Uh, Methylene blue. Oh, this is such a good story. Methylene blue is an anti-tau compound, um, and as an anti-tau compound, it's being studied um, by this group in Scotland with really quite remarkable results. Um, the study that they did most recently, um, that was published a few months ago, methylene blue turns your pee blue. It's a similar compound to the dye that's used in jeans. Uh, it, and so, in order to not have the placebo group in the study be unblinded, they gave a small amount of methylene blue to the people who were also on placebo. So their pee was a little bit blue, and then the full amount, the 16 milligrams, was blue. Lo and behold, the small dose was enough to cause an actual response on the cognitive testing. So what they found basically is that both groups improved from baseline, but they weren't able to separate from a placebo group. So there were no regulatory agencies like the FDA or the EMEA in Europe that would approve the compound. But stay tuned. Stay tuned. I think um, methylene blue, um, uh, so-called HTM, uh, it's going to probably be the first combo therapy with the anti-amyloid therapies.
So, going along with that, what excites you the most about all the
Hmm.
stuff you're aware of?
Well, I had this question. I was giving a talk to a group of folks last month, and had the very same question. And my response was this: um, when you go to conferences that address diagnosis and treatment of Alzheimer's disease, like the Clinical Trials on Alzheimer's Disease Conference or the Alzheimer's Association clinical or conference that's in London this year. When you go to these conferences, you see thousands of young people, like 35 and under. I mean, and these are brilliant young people who want to make this their life's endeavor to rid our world of this disease. And so you get all these young people, presenting these amazing studies, doing this amazing work, winning these awards, and I'm just saying to myself, this is this is the wave of the future. So in the face of a world on fire right now, and regardless of how you want to interpret that, and a lot of uncertainty, one thing that's certain in this condition is that we've got all these young brains working on this problem, and we're going to get to a solution because of that sooner rather than later. So that's one of the things that makes me excited. Um, just just seeing all these young people at these conferences. The other thing that makes me excited is that I get a lot of participants coming into to my research office who really, I mean, they'd like to get some help, but really what they want to do is they want to contribute to making sure that their kids and their grandkids don't have to face this, right? So every single data point, every single study visit, every single dose of a medication, every statistical analysis makes a long-term difference in getting answers to uh, to this problem. And so that's another thing that gets me excited. The fact that so many people are willing to participate and be philanthropic in their effort.
Awesome. So I have a question about antidepressants.
Yeah.
We talk about the apathy that you see in people with MCI and other dementias. Do antidepressants help?
Maybe. Maybe that's the bupropion, that it's the most activating and most dopaminergic antidepressant. So so drugs like Wellbutrin, and so yeah, you could start with a small dose. You don't want to have so much that a person gets restless or doesn't sleep at night. But starting with a small dose and working your way up, that's probably the most beneficial. Sertraline or Zoloft also can be activating, but not it's not as activating as bupropion.
A question related to excessive drowsiness. Is that a symptom of dementia?
It depends. It depends on the dementia. In dementia with Lewy bodies, variable level of arousal and drowsiness, um, it's very common. So a person may be awake but appearing asleep. A person may appear alert but not dialed in. A person may fall off, nod off, in the middle of a meal or some other situation like that. Uh, Lewy body disease affects arousal centers in the brain, and so we see that variable level of arousal, especially in Lewy body.
One more question. Genetic markers. It's a comment, first of all, and then a question. There are genetic markers for FTD, but sometimes they're absent. In these cases, it's categorized as sporadic. How
Yeah.
reliable are genetic markers, and how is it useful to determine if your loved one has those markers?
Ooh, I wouldn't, this is just an opinion, but for FTD, I think the genetic going after a genetic evaluation at this point when we really don't have. There are a few compounds, some sortilin activating compounds that may be beneficial in the future, but for right now, we don't have much on the horizon. So. Um, just this is my personal opinion, knowing well in advance that these behavioral changes are going to occur because of frontal lobe changes. I think we're best off to just kind of toe the line. Um, so that's just my kind of my personal opinion. The experts at UCSF. Um, they're kind of the gold standard folks. So if you don't already follow their work, you can look in neurology at UCSF, and they've got huge databases of frontal temporal folks. Yeah.
So, talking about clinical trials,
Talk about
uh,
clinical
this
trials.
this is your opportunity to ask
Oh,
people to be in clinical trials.
hmm.
I
Yeah.
mean, is there risk involved?
The clinical trials that I conduct, by and large, are medication trials. We have some device trials, but as with any medication, there's always the potential for risk. I would say that the study protocols that we follow um, are so rigid and so safety oriented that you're much less likely to have a problem being involved in a clinical trial than you would be receiving a clinical treatment outside of a clinical trial. For example, for some of you who know about the monoclonal antibodies, you know that a person is most likely to have the ARIA changes in the first 3 to 4 doses of the medicine. So that's with donanemab, that's the first 3 or 4 months. With lecanemab, that's the first couple of months. And so, in our studies, after every visit, you have an MRI. Regardless of whether you have any clinical symptoms or not, we want to know what's going on in the brain. So you have an MRI scheduled. I know, and it can be burdensome, but for safety purposes, we track it very closely. So before a situation can ever get out of hand, we've either stopped the medication, we've done something to modify, whatever it takes to ensure that a person does not have side effects that are going to be problematic. So the studies are well designed, and frankly, uh, I had a woman in the office today who um, she's on apixaban. Some of you know the drug Eliquis, um, and it's a fantastic medication for atrial fibrillation and so forth. It puts you at higher risk of bleeding with one of the monoclonal antibodies, both brain bleeding and other kind of bleeding. It's not an exclusion to put a person in who takes this medication, but it's my kind of personal conviction that I don't include people who are taking that blood thinner in the study with monoclonal antibodies. I just see it as too risky. So, um, yeah, you just because it's a research study and because we don't have all the answers about these compounds, I have to err on the side of caution. So, again, if you want to reach out, it's Summit Research. We're at Montgomery Park in Portland. Um, you might see Summit Headlands. If you do a Google search, you'll get Summit Research. If you search for Headlands Research, you'll see us as one of the members of the 23 site network. Um, and you can just look at some of the stuff that we've done, some of the research we've done over the years, um, and you can always reach out to us, uh, and we're easy to find. We have a network of people who answer the phone. Granted, it's 2026, so some of these people they're not overseas, but they are some of them are in San Diego, um, and so you can always reach out.
So if with your permission, we will share your slides.
Sure. Yeah.
And we'll also share information related to how to contact you. We do have someone, Liz from Southern Oregon, says that she wants to be in a trial, or please, I've been diagnosed with cognitive impairment and am a caregiver to a husband who has dementia and
Mm,
Parkinson's disease.
yeah. Yeah.
So we will be happy to do that. The last
Okay.
question that we try to ask anybody who is nice enough to speak for us is, what would you like people to know?
Oh, that's a really good question. I'd like people to know that um, their situation, although difficult and at times very challenging now, is being worked on diligently by a lot of really brilliant brains, people much smarter, much younger, much a lot more energy than I have, and that your kids and their kids are probably not going to have to deal with this scourge of a disease. Um, so uh, that's where the hope is. I mean, you guys have hope in your the name of your organization, and your hope is based on human connection and support. Um, and this hope is it's not different. It's just a different type. It's a different type of of contribution to the greater good that will ultimately benefit our kids and our kids' kids. So that's
That's
that's a
about
good
the
point.
best thing I've heard in I don't know how long. So thank you for that.
You got it. Yeah.
And thank you for presenting for us today. I'm
You're
sorry.
welcome. I apologize for the technical difficulties, everyone. I hope you have a very pleasant evening.
Thank you so much.
Okay.
And
Bye-bye.
everybody, so that you all know, our next education next month will be Joyce Beadle, who is a dementia educator out of Portland, who will be talking about when the relationship changes. So thank you all. We also, on May 15th, will be having an all-day workshop at the Water Resource Center, which is specifically related to uh, another version of caring for the caregiver. So thank you all for being here, and we'll send out the information soon. Remember that the recording will be on YouTube, and that is the Hope Dementia Support YouTube channel. So thank you all and have a good evening.
Bye-bye, Lynn.
Bye-bye. Thanks a lot, Scott.
You got it. Bye-bye.